Hello, everyone. Welcome to today's webinar. It's all about Exudate management. My name is Maria Lopez, and I'm the head of marketing at Mölnlycke. Before we get started, please submit your questions by typing them into the Q&A box of the control panel. You may submit your questions at any time. We will collect them and address them during the Q&A portion at the end. I'm very pleased to introduce our guest speaker today, Dot Weir. Dot is a certified wound and ostomy nurse and a certified wound specialist. She is the co-chair of the Symposium on Advanced Wound Care, faculty of the Wound Certification Prep course, and secretary of the International Wound Infection Institute. She practices clinically at the Saratoga Hospital Center for Wound Healing and Hyperbaric Medicine and is a national and international consultant and educator. Welcome, Dot. It's a pleasure to have you here today.
Thank you, Maria, and I add my welcome to everyone. Thanks for joining us after your busy days. So I'm going to be talking about something that's near and dear to my heart, and that's just about exudate management, but I'll be specifically talking about how we manage exudate in the clinic in which I work. So again, I thank you for joining us. So I am on the Mölnlycke Speakers Bureau, and I have been since probably 2006. So I've been using their products for many, many years. And so I'm going to be focusing on how we manage exudate using their products. So these are our objectives. Exudate's a big deal, and I think you'll find it a bigger deal after I finish tonight. We'll talk about the differences in some of the gelling fibers. And then we'll talk about by using cases, how a combination of the gelling fiber and the superabsorbent foam that Mölnlycke has can make a difference in your patients. So let's get started. I don't think if you all do wound care, I don't think I have to tell you the challenges that we have with exudate. We have challenges with maceration, with erosion. And when I mean erosion, look at these wounds, that top two. You can see that the skin has been eroded or eaten away by the exudate. This leads to a significant amount of pain for patients, and then they have the ability to become secondarily infected on their wound because they can cross-contaminate over from the skin, which I'm going to show you examples of. But we all know what it also does to impact their quality of life. So many folks will hide in their homes. They don't want to go out. They don't want to be around family because they feel like they smell. They feel like the exudate is unsightly. They worry about getting it on their linens and into their, onto their carpeting and soiling their clothing. And then certainly it impacts everyone when it comes to the cost, because it takes more frequent dressing changes. And many people don't have access to care. In other words, they don't have a family member who can come in and change their dressings for them. So they have to rely on outside sources. So, of course, we're always going to provide the appropriate supportive care. If it's a venous leg ulcer, we're going to compress it. If it's a plantar diabetic foot ulcer, we have to find a way to offload it. If it's a pressure injury, we want to make sure we're identifying it correctly as a pressure injury and making sure we're not calling something like moisture-associated skin damage, as you see here, or skin tears on the lower extremity. We don't want to be calling those pressure injuries and then also staging them. That's a big deal here in the U.S. And then there's the bane of all of our existence, those arterial ulcers that hopefully we can get revascularized. And if not, then we just want to protect them so that they, provide some pain relief because they can be very painful. And then there's everything else. In our clinic, we have a very low bar or threshold for biopsy, because as I go through the slides, the pictures that you're going to see at this bottom right, what you're looking at there is a malignant melanoma that this gal walked around with for a couple of years. And the reason she did is because she was afraid of what she'd find out. And it indeed was a pretty bad cancer. Scleroderma, vasculitis. This is radiation injury from a big squamous cell cancer that the person had radiation and had significant injury from that. And so this is just a picture of the biopsy, knowing that we need to send this off to the lab and be able to identify earlier rather than later that we're not just dealing with, say, a venous leg ulcer. When we have exudate challenges, we see things like pocketing and pooling. I think you can see my pointer, but I'll come back to, I think I have this case in here, but I'm not sure. But anyway, when we have dressings that are in place, but if they're not absorbing and wicking it out, then we're going to have pooling issues. You can see the one on the bottom. All of these are examples of that. The middle patient, I'm going to show you that case, but look at that top right. So when I talk about exudate management, we usually need two products at first. And I liken it to a good baseball team. You can have a great pitcher, but if you don't have a good catcher to catch that pitch, they're still going to lose the game. So we may have good absorbent products, but if those products can't pass that exudate into a secondary dressing, we are still going to be dealing with erosion and maceration around the edge of the wound. The bottom one, I will tell you that macerated skin holds bacteria like nothing you've ever seen. So this is a pressure injury. You can see there's a lot of necrotic material here and some macerated skin here. Now we have an imaging device that shows us where the bacteria is. If it's bright white, it's a hot white sort of cyan color. It's usually Pseudomonas. Everything else is red. So if you look at the fluorescence image of this, you can see some Pseudomonas here, but see all that red that's in the surrounding skin? See this red that's down here? I'm going to go back. That was all in the maceration. So that's why exudate management is such a critically important thing, because it's one thing to pack the wound and clean the wound, but if you don't get to the peri-wound skin and get that cleaned up, as well as absorb exudate well enough so that it doesn't sit on the skin, then we're still going to be dealing with a bacterial issue. So there was really a big need for products that could meet both our basic and our very common needs. And that is something that we could use to pack wounds, would absorb adequately, but also send that exudate into a secondary dressing, and then a dressing that can handle that exudate. So I was at the European Wound Management Association meeting, and this goes back to now, I think 2018 or 19, whenever it was in Gothenburg, Sweden. And I was going to actually meet with the people from Mölnlycke to hear about Exufiber gelling fiber for the first time. And first of all, she was telling me that it was a polyvinyl alcohol fiber. And I was like, no, PVA, polyvinyl alcohol is a foam. So who was I to argue with a scientist? So I did anyway. Then she convinced me that it can be made into a fiber. And so I still came home wondering, I need to understand this better. So I just did my own search, and then I came across this particular paper, and I am never going to sit and criticize another company's product. So I don't even know what the product on the left is. I only know that they were comparing themselves to the Exufiber. And so what you see in the larger photograph is the actual fiber in its dry form. And then in B here, that is when the exudate has absorbed into the product. And this little red square here is this cutout right here. And so what you can see is it did a very nice job of absorbing the exudate and locking it in. The challenge is that we need it to go through the dressing. So they were comparing it actually to Exufiber, and this is the Exufiber in its dry form. And this is a blow up after it is completely hydrated. And what you see is you still see the strands that are in there, but you'll notice there's still space. And that is what's enabling it to continuously pull the exudate out and into the secondary dressing. And so I coupled what I learned in Sweden, I coupled what I read here, and then what I began to see clinically to make my decision on the preference of this particular dressing. So that's our pitcher, but we need a good catcher. So several years back, around that same time perhaps, the design changed with Mepilex Border, and they came out with Mepilex Border Flex. It looks kind of similar to the regular Mepilex Border, which I believe they've completely replaced with Flex. But I'm going to show you the 5 layers. So down here, we have the known soft silicone layer that we've been using for so many years. We call it SafeTac here in the United States. There's a thin foam layer that begins to pull up normal as well as thick or viscous, slimy kind of exudate. And then it gets to 2 spreading layers. Well, this first spreading layer brings it up and moves it out into the dressing laterally, as well as begins to show us how it can flex and move. And that's the Y cuts, which I'll show you. There's a second layer that's thicker that will retain and hold on to that exudate finally as it's spread it out. And then there is a backing that is shower proof, but it also has a high moisture vapor transmission rate. So the moisture vapor can evaporate out, and it does allow it to hold a tremendous amount, which I'm going to demonstrate for you. Now, what's the big deal about the Y cuts? I always joke and say that these Y cuts, they remind me of those big windmills that are used for power. That's the exact shape that they are. So it does a couple of things. It provides more surface area, if you will, because the slits are there for the exudate to get in and move out. But the other thing it does is it makes it more flexible, because we don't want a dressing that when we put it on, if the area that of the body that's on flexes, that it might either pull on the skin and cause some problems, or it will pop up. So that's why with the slits in it, the Y cuts, then you get 360-degree stretch all the way around. And so when they compared it, and I took the comparators out because I don't think that's as important as just feeling good about what you're using. And so when you compare, what you want is a lower number. In other words, you want less force to be able to stretch the dressing. And compared to some of the other dressings that were similar on the market, it had the less force that was required for extension. So it's going to mold and stretch better in your hard to hit or hard to seal areas, which I'll show you a couple of pictures. So let's look at some cases. So this was a lady who came in, and I mean, no one could look at that leg and say all is well. This was her first visit. This was during COVID. And I will tell you that when the pandemic started was just when we were opening our brand new clinic with these products. And they were just an absolute godsend because we couldn't see our patients that frequently. Home care was challenged. Anyway, all this that you see, this is the lateral part of her leg, is all from Exudate. It had just gotten out of control in home. This is a close-up of the actual wound itself. And then this is the more medial area. So you can see these were on the 22nd of April, and you can see, so most of it was on that other side of her leg. So what we did is we cleaned her up. We used a medication, a combination of an antifungal and a steroid ointments in that area. I kind of made my own little windmill out of Exu fiber, and we did use the AG, the silver Exu fiber. And then that was on April 22nd. You can see 7 days later, because we were able to move it. We weren't using the border flex on this because I didn't have one big enough. We were using a different super absorbent that acted as a good catcher, if you will. But you can see just within 7 days, by controlling that exudate, we were now in a much better place. So then it got down to where we could focus on the actual ulcer, which was just in the fold of her leg. This is the exu fiber in place, and this is the border flex, and you can see it's molding in nicely. And as long as your wrinkles are completely sealed, you can see a little wrinkle here, but as long as the edges are completely sealed, then it becomes shower proof. So here's another case. This was also during the pandemic. This is a gentleman that a local CWON had sent to us because she had to close her clinic during the pandemic because her clinic was a nurse-run clinic and it was in the middle of the hospital. They did not want outpatients coming through the hospital. So he was left to his own devices. She called us and warned us that he absolutely was adamant that he could not handle compression. We'll come back to that. But what he was doing, he was buying 100 ABD pads a month on Amazon. You can see he was painting his leg and just slathering it up with zinc paste and changing it a couple times a day. And then or 2 or 3 times a day. And then he was purchasing his own Una's boots, but only wrapping it from his ankle up to his knee. So this was the first visit. This was after I used a lot of mineral oil to get all of that zinc paste off. And now you can see what we ended up with. His real ulcers, if you look at the second panel at the bottom and the third, those little areas that are sort of yellow, those are his ulcers. The rest of this was all moisture-associated skin damage, erosion from his exudate, which kind of makes sense. He sat with his legs up, but it all pooled around towards the back of his calf and caused all of that pretty near full thickness erosion. So we put Exu fiber, and I did use the AG on this. Exu fiber AG, again, wrapped him with some super absorbent dressings, and then had a conversation with him about compression. That's a whole other topic, but we have to find a compression that works for people. It's not a one size fits all. He had had Una's boots and Coban. He had had multi-layer wraps, 3 and 4 layer wraps. And he said, I can't tolerate them. So we were going to use a 2-layer wrap, and we gave him, number one, permission to take it off if he couldn't stand it. But we brought him back in 2 or 3 days because, as I'll point out in a moment, once you start reducing volume in a leg, you're going to have a lot more drainage, and you've got to be able to handle that. So we made him an appointment for 2 or 3 days later. And when he came back, that's what he looked like. So much better. The challenge is I didn't see him this day. Right up here at the top of that calf, something stuck. I'm assuming it might have been the extra fiber had sort of stuck to the edge here. The rest of it was dripping wet, and he has fairly low pain tolerance, and so we said, okay. And so the nurse that took care of him that day put a different kind of thick foam dressing that was not multi-layered and rewrapped him. So this was 3 days later. And then when he came back the next time, which would have been another 2 or 3 days, he was totally broken down again. So I had this conversation. I said, we'll continue to do this twice a week. I will make sure nothing sticks. And we've got to proceed in a way that we know is going to work. So we started then. And this was the end result. So the final analysis, 10 weeks later, you can see the volume reduction that we had. And I liken it, well, I'll show you my analogy in just a few moments. But you can see we had a tremendous amount of volume reduction. And so we were able to get that fluid under control. And then he went right back into compression socks, which he wears all the time. So this is another fellow. We share a wall. That clinic that you can see in the background, this was our temporary clinic when we first opened up. We now have a very nice clinic that's right in Saratoga Springs. And so this fella had obviously a 5th ray resection. He had become infected. He had a debridement and a flushing out. And so then the podiatrist wanted his wound packed through and through. She wanted to keep that tract open so that it did not accumulate inside there. And so I don't know if you have any of these metal probes that you can see here in this photograph, but they are worth their weight in, I'll say gold, but they're actually stainless steel. So they're worth their weight in stainless steel. And so the cool thing about them is that they're called an eye probe, but I think the eye means that it has this like eye of a needle here. And so we were able to loop, again, extra fiber AG ribbon this time through the eye of that probe and pass it up and through his wound. And then you can see the end result. We then layered a little bit more at this area. And at that time, even our 6x8 did not cover this correctly. And so I tried to overlap 2 borders, which I was not successful. I'll show you what happened, because obviously that border in the middle there is not going to absorb anything. I now would trim that particular part of the border off if I was, and that's not a Mölnlycke thing, that's a Dot thing, if I was challenged in space like that. But what I like to point out is this is what the dressing looked like as it came out. There's some concern expressed sometimes that it's going to break. And I mean, you don't have anybody at the other end playing tug of war. You cannot cut this really, really skinny. Anything can break then. But, and we did trim this down just a hair though, but you can see that with just gently pulling it out, it came out in one piece. And so that was our management until his infection was cleared up. Then we went back to negative pressure. This was another gentleman with a tremendous amount of Exudate. He had had a hip replacement and he had had it redone. He had a hip replacement, it became infected. He had a second one done, and then he developed this tunnel, which, you know, most of the time, as you probably know, means that the hardware inside has become infected or that there's a biofilm and it's not allowing the wound to close over it. He did not want to have another replacement. I've only had one. I had my right hip replaced several years ago, and I wouldn't want to go through it again 3 times on the same hip. So this was how he presented to us. He had a 7 centimeter tunnel going straight down. That wound is larger than it really looks, so we were able to use the extra fiber, and again, we used the ribbon and we used the silver ribbon, and packed him. So what you're looking at is June 10th, and now you're looking at October 29th. So it took a few months. He was put onto long-term doxycycline, and he is on lifetime suppression with doxycycline. He comes in to see us about every 6 months to get his doxy refilled, and he is still closed. So it is not that it was such a miracle for his hardware. What we had to do was remove that exudate in order to keep it from pooling in there. So this is his dressing when he came in twice a week and we packed him. This is the dressing. Now, here's the rule of thumb when you're using Mepilex Border Flex. The company recommendation is that you change the dressing when the exudate has hit 3 sides. I would recognize that we have a 4th side here, but it was pretty loaded. And I think anybody would look at that and say, OMG, what am I going to find underneath this? Well, what you're looking at in the next panel is actually the skin side, the wound side of that dressing. So what is important here is that you can see it has, the layers have pulled it up and trapped it. This is just the little piece of exu fiber that was adherent to it when we took it out, so we didn't have to worry about retrieving it. And so it just does a great job of absorbing and moving it out so it's not pooling against his skin. This is a very similar case. It was a young girl. She's 25 years old. She was 3 weeks postpartum. She had a seroma. But again, we couldn't get her home care, and she had a brand new baby at home. She did have an infection. She grew out groupie strep, so she was treated with amoxicillin because she was still nursing. And so we packed her with Exufiber AG ribbon, used a Border Flex, which I'll show you in a moment. And by 2 weeks in, she was down to 4 centimeters. She had been, it must have, I don't remember what the initial tunnel was started at, but it was down to 4 centimeters. 8 centimeters. It's on the slide. I have another screen over here. So she went from 8 to 4 in 2 weeks, but she was 25 years old too. So she was healthy otherwise. She just had a little seroma. She had a little tummy on her. So this was her first dressing change. And again, the rule of thumb is to, leave it if you change it when you see 3 sides, but we didn't have that option with her. So she came back in. This is after it's removed, but this is the underneath side of this very dressing. Sorry, it's a little blurry, but she, with the top edge was flat. She was able to shower every single day. You can just imagine, I'll show you that as her exudate reduced, you can see her dressings. And then of course, she continued on till she closed. But she was worried about contamination with her new baby, but she closed up really quickly. So this is a gentleman who a lady who had a basal cell cancer of her right lower leg. I'm showing you this to talk about peri-wound again. She came into us, you can see she has some other comorbid conditions, autoimmune stuff, and she came into us that she'd had this thing excised. She had a negative pressure device on, and it simply was not changing. So this is using that imaging device. So she had a lot of pooled exudate, but the wound itself definitely had some fluorescence in it. So when you see red fluorescence, that is most every other bacteria except for strep. Pseudomonas is cyan, and then every other bacteria is, especially staph and stuff is this red color. So you can see she had it not only in her wound, but look at her peri-wound skin. So what we did is we scrubbed her up. We use a hypochlorous acid. First, we painted the whole area with povidone iodine, and then I went to work on that peri-wound area with some hypochlorous acid. And this was immediately following. So we were able to scrub her up really well with hypochlorous acid and got all of the bacteria out, or the fluorescing bacteria out of the wound. And just as a point of reference, when you see color with this imaging device, you're seeing at least 10 to the 4th bacteria. So her wound's not sterile. It's just down below a colony count of 10,000. And she still had some adherent, her skin, short of cutting into her skin, which we're not going to do, then she had significantly less. And then the next week, she wasn't fluoresced. This was where we started again. And this is after just using a week of, actually, on her, they just used the Mepilex Border Flex, and you can see her wound is starting to clean up nicely. So this one is fun. I'll go ahead and start this video for your entertainment. So this was a lady who had a shoulder infection. She'd already had one shoulder replacement. They did not want to do another one, but again, this was during the pandemic. So she drained so much. I mean, so much. So of course, the orthopedic folks said, "Can't you just get this to close up?" And that wasn't going to happen. But what we did was we irrigated her out as much as we could, expressed as much as we could, and we even tried a snap device. If you're familiar with the portable, the wearable, mechanically powered negative pressure device. And so it was overwhelming. First a 60cc cartridge and then 150cc cartridge, and that was going to be cost prohibitive. So we began to pack her with a long piece of Exufiber AG ribbon. This is when she came back. You can see, and I apologize for the blurriness. And two of her sides were almost completely filled. But again, this is the underneath side, and this just shows how nicely it flexes over her shoulder. So this was the underneath side of her. We never got her closed. We just maintained her Exudate twice a week until she was able to get into surgery. So this is a lady, it seems like all these were during the pandemic because that's when we were first trialing it. We're not trialing it, first I put it into stock, but she developed a spontaneous perianal abscess. We knew she was going to have surgery, but we again had to maintain it because they weren't doing elective surgeries. She was otherwise healthy. She was slightly obese. You can see her initial measurements, but she undermined 4 centimeters circumferentially. She did not, and I can respect this, she did not want her husband doing this dressing change. And so because it wasn't an essential surgery, we had to come up with a treatment plan. So what we did was we used some Marathon at first because we wanted to keep it nice and dry, and we weren't 100% sure how well everything would stay on. But we didn't have to use that for long. We packed it with the Exufiber AG ribbon. We used a 3x3 Meplex border flex. Picture framed it with silk tape because she wanted to shower, and then we changed it twice a week, and on the day she was coming in, she peeled it off so she could take a shower, but she showered every day. And so by day 12, that secondary area had opened up, and we did this until the restrictions were lifted and she could go and have it surgically corrected. But by that time, she went from 4 to 2 centimeters, but she definitely had a space in there that needed to be surgically corrected. So this is the gentleman that was really grabbed hold of me because he was 53 years old. He had a squamous cell carcinoma of the larynx. He had had it for 3 years, many rounds of chemotherapy. He was no longer a candidate for chemotherapy. He had had 2 rounds of radiation. He was also had diabetes, but we weren't going to cure him at all. In fact, he was with hospice, but he presented because he had this tumor that was exteriorized on his lateral neck, which was painful. It drained a lot, and it was full. And so it was actually pushing in on his neck, so it was preventing him from swallowing. So this is what it looked like on the first day he was there. And although that looks pretty solid, this was, I'm going to use a real good medical term here, this was real mushy. And so we could actually probe down into it. And so this was where we packed with a wick of Exufiber AG, and we did have to cut it more narrow, but there was not a space here. We weren't going to lose it. And so we packed it in there, and we covered it with Meplex border flex, and we gave him some to take home. So he came back in a week, and he had less pain. The exudate was contained. It was getting a little bit smaller. And by 2 weeks in, it is significant. The opening and the depth of the actual cavity was smaller. He had very little pain, and now it had decompressed it enough where he was able to swallow soft food. And then he came back to see us at 4.5 weeks. We ordered his supplies through a medical supplier. The lesion had completely closed. He was eating solid foods. And I mean, again, this was just improvement in his quality of life. But I will tell you that I pulled this case out maybe earlier this year. And this was during the pandemic. So I was very happy to see that, because I didn't go into his medical record to see how he's doing. I went into our record of his past visits, but he is still alive. And so I was very happy to hear that, because he has a very bad cancer, but somehow they've been able to manage him. So going back to venous leg ulcers, I mentioned that these are highly exudating. This was a gentleman, excuse me, a lady who no, so is a gentleman, excuse me, I gotta move something there, who came in, and of course you're going to have a lot of it. This wasn't a deep ulcer. You're going to have a lot of exudate when you first start compressing someone, because that fluid's got to go somewhere. And I liken it to a hole in a garden hose. The water's going to squirt out. And so you can see how much we were able to decrease her just in the first 5 days. I keep calling it her, decrease his volume in the first 5 days. His ankle alone went down 8.5 centimeters. And so this is what he looked like. I mean, nobody really trusted anything. They actually put zinc around there, but you can see that dressing is loaded, but you can see on the underneath side that it wasn't pooled. And then we just continued that same plan of care, of course, with compression. The ulcer itself was not hard to heal, and he went on to close. So then I want to also lastly share with you a quality improvement project that speaks loudly to a couple of things. One is, it's easy to say we want to always be cost effective. That is first and foremost, and I'll mention that again. But we also have to use things that work. And I know that if you do wound care, then the best thing that we can do is leave a wound alone. Especially once we have it well prepared. We want to practice undisturbed wound healing. And so this was Deborah Nelson, who was at Cooksville Regional in Tennessee. They had arbitrarily changed out their foam dressings, and both the wound team as well as the staff were not happy about it. And so they went to value analysis, and they said, it's penny wise and pound foolish when we're going to have to change these dressings more often. So they agreed to let her team do a quality improvement project. So they had 19 patients. This was looking at skin tears. And so they had 19 patients. There were 42 wounds included in the evaluation. And the average healing, they healed 78.2% of them, but the average wear time on these dressings was 6 days, and 11 of them healed in the first week that they wore the dressing. And so the results is that they were able to show evidence-based changes, and they were able to go back to a Mepilex BorderFlex facility-wide. But what I love about this is that when I've heard Deborah talk and tell this story, is she described it as a culture change, and it truly is. Because we a couple of habits that we need to change. If you work an outpatient, you've seen plenty of patients that came in that had a skin tear and had layers and layers or lots and lots of steri strips on, and then somebody's got to get those off, because many times there's a lot of pooled blood and stuff underneath them. So this was a patient with a bad skin tear, grade 2 stage 2 skin tear on her knee. So this is the dressing in place. This was during their study, and they wrote the measurements around the edge. And this is such a great idea. In her case, she always put an arrow to point to the direction, the area that needs to be lifted up. I tend to make my arrows on the top in the direction I want a patient or somebody to pull it off. So you just have to agree on that. But she put pull from here so that they would pull in the right direction, because you don't want to lift the flap of the skin up. So this is where they started once they got all the steri strips off. And this is 7 days in a 6x6 dressing, and it was completely closed. So, the culture change is that this isn't the same patient, but the culture change is that you have to get people used to seeing this exudate on top. It can be unsightly. They can say, oh my goodness, because we're used to seeing pooling, but you can see in this particular skin tear, it was healed when they took it off or closed when they took it off. And you can see that there is not pooling underneath. So in summary, and then I'm going to have time to get to your questions. I think I have about actually 15 or so minutes. It's a challenge to balance undisturbed healing with exudate management. We know that the less often we change dressings, we're going to save money. We're going to interrupt the healing less. We're going to have less cooling of the wound. And we know that can take a while for the cells to sort of recover from having exposure to the outside air. And we do have a lot of tools in our toolbox. And this just happens to be one that hands down in our hands in our clinic has worked the best for that catcher-pitcher analogy that I gave, that we can actually, because of the nature of the dressing, wick and pull and transfer it into the secondary dressing. So I want to close with just in the United States, we had healthcare reform back in 2008. It was a government program. And what they wanted, it was a money-saving attempt. And our whole insurance system changed. But in any event, I mean, we still had insurance, but it's just changed that everybody had to have it. But anyway, the Institute for Healthcare Initiatives in 2010 described something that they called the triple the triple aim theory. The triple aim. It left me for a minute. And it was a three-tier thing. It was they wanted healthcare in the U.S. to have improved clinical outcomes, but with a lower cost of care. So we're supposed to take better care of people, but not spend as much money. But at the same time, we wanted increased patient satisfaction. And we live and die in this country by satisfaction surveys and surveys that are sent out to patients randomly. And these are like report cards for hospitals. And so, you know, that's our challenge even today. This was 13 years ago that this came out, but this is still how I like to think about how we practice. Improved clinical outcomes. You know, patients are complicated. We've got all this scrutiny. Nothing's easy anymore. Our patients are sicker. They have more comorbid conditions. We always want to be practicing evidence-based care. We just have to be cost effective. And so even though a product may seem more expensive at its purchase price, if it stays in place longer, just think if you're in home care, if you could cut just one visit a week, you're going to save significant funds and significant amounts of money. So we coordinate all that with our home care folks, but always keeping that patient at the center, because it's that patient satisfaction and quality of life that really makes us all get up and go to work every morning, I believe. So with that, I say thank you. I want to say thank you to those two little puppies that are in this picture, because they're both asleep, sound asleep on my desk, and they did not make a peep. And my husband who's making dinner. So anyway, Maria, I will leave it open to you and we'll answer some questions.
Thank you very much, Dot. This was a very insightful session, and congratulations for those little puppies. They're very cute. So as you know, now we're going to move into the Q&A part. You still can submit your questions. We have lots, so I will just try to cover them all. So I will start here, Dot. So the first one. So before the Mepilex border, do you put something first?
No, that's a very good question. With any of the silicone dressings, and this could be the silicone negative pressure drapes or any silicone dressing, the way silicone attaches to the skin is that the silicone, as it sits for a while, actually sort of settles into the little spaces between the cells on your skin. So if you put a coating on it, then that coating is going to prevent that from happening. So your adhesion will actually be worse if you use a skin barrier wipe underneath a silicone dressing. And the thing about the silicone, at least with most of them, you can lift it and put it back down. Let's say you do get that wrinkle. You can lift it, separate it out, and put it back down in the first couple of minutes. And if you've put a barrier wipe on there, then you're going to be lifting that. It won't stick again. So yes, the only time, like I used Marathon, which is a cyanoacrylate in that one, because we weren't sure what the Exudate was going to do. And so we just were trying to degrease her skin somewhat, was really more the point. But once we saw that it was working fine, then we stopped doing that.
Okay, thank you. Then is there harm in changing it before it gets to 3 sides?
No, not at all. That's the maximum. That's the Mölnlycke Healthcare's recommendation for changing Mepilex Border Flex when the Exudate has hit 3 sides. As you can see, we've had many that hit 4 sides, and a lot of those are those that are used under compression. So, and they handle it just fine. But the recommendation, I think, in the package insert information for use is to change it when it hits 3 sides.
Okay. How does viscosity affect efficacy of absorption?
Well, we have found so far, because the contact layer, the safe tack layer, allows the exudate to come up through because it's pretty porous. And then the various layers have the ability to wick and spread even viscous exudate. Do you remember the lady I was squeezing all that cheesy stuff out of her shoulder? That was pretty thick, and you can see that it absorbed into the exudate. So it does a really good job with viscous exudate.
Does application of zinc under a silicone foam dressing reduce absorption?
Okay, could you ask that again?
Zinc. Does
zinc. Okay, no.
Yes.
That was early on for us, and I didn't do every single one of these dressing changes. And so we are very habitual about using barrier ointments surrounding wounds that are draining a lot, because we're so used to actually getting on the skin and causing maceration or erosion. So that was an example that was early on, and that's how the nurses that in my clinic decided to do it. But we know, in fact, it's better if you don't, because then the Mepilex border flex will stick and adhere right next to the wound, and then the wound exudate will travel up that pathway into the dressing. So that example was not a good one. I just was showing how much it held. So we don't use barrier ointments underneath this particular one. We have other foams, but they don't absorb in the same way. And so we might use them under some of those, and even some of our other super absorbents. But because we want the border, the silicone safe tack to stick well to all the skin in the period when we don't put anything around there.
Okay, thank you. What is the 4-layer compression? I'm familiar with only CWON or edema wear.
Oh, okay. So in the world of compression, there are 2-layer, 3-layer, and 4-layer. So the CWON 2-layer is obviously a pre-stretched 2-layer. That's the one we use. That's our preferred. Edema wear, for those of you that are not familiar, is a very interesting. It looks almost like fishnet, but once it's much more scientific than fishnet. But it's different from like the retention type of flex net that we have to hold dressings in place. It's tight, and some of the leaders in edema management for lymphedema use it. Susie Eman is one out of South Carolina that uses it extensively. So it's just and some people put it on first and put dressings over it. We don't stock it, but it is used a lot in lymphedema. And then you have 3 and 4 layers. 3 layers usually have a cotton layer, a crepe layer, and then I don't want to use it. Well, it's CWON, but a self-adhering layer. And then the 4-layer has the cotton layer, the crepe layer, and then it has a long stretch that you wrap in a circle of 8. So you get greater compression with 4-layer, but it's heavy and it's hot, and a lot of people don't like them so much. The 3 layers for people who don't have great perfusion, and then the 2 layers are nice for ambulatory patients. It helps their shoes fit better, and it gives less pressure when they're laying down, so it's more comfortable. Hope that helped. That's a huge lecture all in itself.
Another webinar for that. So is it always good to apply steri strips for skin tear when secured with Mepilex for better wound healing?
No, you do not want to put steri strips onto skin tears, because they're going to get soiled before that skin tear is closed. And so now you're going to have pooled blood, and I always point to my hands because so many of them are on their hands. Then you're going to have pooled blood underneath the steri strips. And then if you try to take it off, now you've got fragile skin that you're having to peel off tape. I recommend starting, if you don't have border flex to put on initially, use a Vaseline gauze, a Xeroform gauze, a contact layer like Mepitel, so that it will not allow anything to stick, but the exudate can still come out.
Thank you. Does packing need to be changed daily if saturated?
Well, that's the beauty of this particular one, is that it's going to keep pulling it out. It's like having almost like please understand, I'm using this analogy that has just popped into my head. This is not any kind of a claim on the part of Mölnlycke, so I need to make sure you understand that. But you know, they put Penrose drains in as a chute, as to keep something open and allow exudate to come through. And so these fibers, because they don't become one solid mass, will absorb, and then they continue to allow the exudate to pull and move through. If you get a hold of some, you can just put it into a glass and let it drape over the edge, and you'll see for yourself that it continues to move fluid. But so no, for that reason, we do not have to change it daily. And you know, a lot of our fiber dressings, whatever you use, don't have to be changed daily unless they have a lot of exudate. When we have a patient that has a tremendous amount of exudate, when we first start, we'll probably change it a couple of times a week, and then go from there. But our ultimate goal is to get to once a week.
Okay. Does exu fiber packing come out in one piece? Is there any residue left behind?
No, it will come out as one piece. It does not dissolve. That's why the recommendation of the company is that you don't cut it skinny. Because of course you're going to affect the tensile strength of it if you do that. We have made it a little bit more narrow, but not even halfway. We don't ever even cut it halfway. We may just cut a little bit off the edge, but that is that is how we do it. That's not Mölnlycke's recommendation. Their recommendation is that you do not trim it at all. But when you're pulling it out, you just need to gently kind of just pull. You don't want to jerk it out, but you just pull, and it comes out very easily, because really it's sort of slimy by the time the exudate has gotten into it. So it comes out pretty easily, but it will not dissolve.
Please, what can we use to heal and stop bloody exudate in skin tear patient not on anticoagulant?
Okay, well, that's a whole other problem. So there are, I would hope that, and we should all have access to some sort of a hemostatic agent. We've gone through several in the years. There's Surgicel, there's oxidized regenerated cellulose. It's a little pricey. There is something called Quick Clot, which is a kaolin-based gauze, but that requires some attention. It works well. That's what they use actually and have used in the Middle East in the wars. But what we have is I guess I can use brand names. This isn't for CE, so I use brand names. There's Surgifoam or gel foam. And what you break off a little piece and you put it right on top of it. And then we just put a border flex over it usually. And then it will cause the blood to clot. If it's just minor punctate bleeding, I guess you could try silver nitrate. That's a little painful for some, but we tend to want to try to use a hemostatic agent. Otherwise, if you're stuck somewhere and you don't have a hemostatic agent, then pressure. You just have to put gentle pressure and don't peak. One of the other things that I find, if there's one little spot that's bleeding, I will wet a Q-tip or sterile applicator and put direct pressure with that one piece of cotton right at like sometimes after debridement, she'll stop the bleeding, but there's one little spot that keeps bleeding. So I'll put direct pressure on with a sterile applicator because I can put really good pressure on, but make sure it's wet, or even put some jelly on it if you have it so it doesn't stick.
How many days before you change the Mepilex?
We don't go farther than a week. Now we have, but that's not been on purpose. It's because either the clinic was closed, we had a snow day, or something happened that they couldn't get the dressing changed. But the indication is to change it after 7 days.
Can you tell us what to do in case of you have a lot of fibrin risk? Can you add hydrogel with exu fiber?
Well, that's sort of defeating the purpose. If you have a lot of fibrin, say the second word.
Fibrin risk. I don't know, that there's risk for fibrin. I don't know.
Okay, so I think what they might be asking is this: there's a risk of the exudate congealing on the surface. Fibrin is a very specific component of blood, and so a lot of times people will use that to describe sort of a yellow coating that's on the wound. And I believe this is where I put my wound hygiene hat on and say, numb the person up if you can. We use a lot of lidocaine jelly, and see if you can get that off. If you can remove that slimy surface, then usually if you use a good wicking product, then it should not reform. If I'm understanding what they're visualizing and what they're asking about.
Okay. I have a resident with an open wound to intergluteal cleft. We are using Mepitel AG and Mepilex border. Any other suggestions? I can't seem to close it.
Pressure injury, did it say what kind of, it says a wound, an ulcer?
No, intergluteal cleft.
Yeah, I know where it is, but what kind of a wound is it?
Oh, that's it.
Okay. So anytime you are doing all the right things, which I'm sure you are, and something doesn't close, you got to go back to the drawing board and try to figure out. I would suggest to you that you pull a paper called wound hygiene. Go to woundhygiene.com and pull a paper on wound hygiene. Many times just changing your wound bed preparation, if the person can tolerate it, do really good mechanical scrubbing. I'm not going to call it mechanical debridement. I'm going to call it mechanical scrubbing. And especially if you have access to an antimicrobial solution to clean with. If you don't see epithelial cells migrating out, then and it's building up exudates, then it's a bacteria problem, I think, not infected. The other thing is maybe the wound cells are just sluggish, so they might benefit from a little debridement, or even a more advanced dressing like a collagen may stimulate that. Or you could have a hostile environment, and so if you use a collagen dressing, it could lower the proteases. So but I always feel like we all do wound care. We think we can handle most things, and I believe that we have to have the good feeling about asking for help. This gentleman that you see in this picture is my husband, but he's also the medical director of my program, and so we work together every day. And it's nice because he'll call me in, and we bounce things off of each other. So depending on where you work, get another set of eyes in. It's amazing if somebody hasn't been with that patient for a long time, and somebody can walk in and have some brilliant ideas like that Hawaiian Punch commercial. I wish I would have had thought of that. So I would send them to a wound center if you have that ability. I know Canada may not have wound centers on every corner like we do in the US, but try to just get a consultant in or somebody else if you've tried and you just aren't getting anywhere with it. None of us heal everything. I mean, I feel good about what I do, but we don't heal everything. We don't close everything. And sometimes we cluster and we hop things back and forth and figure out what are we missing. And sometimes that helps.
Thank you. Here, there are many other questions. I think we won't be able to answer them all, but let's.
Yeah, we got plenty of time.
Yes. Okay. Is it enough to apply just a Mepilex for exudate wound, or apply another type of dressing like alginate, AG, or silver cell or gauze before Mepilex?
You could use Mepilex Border Flex for any wound over any type of dressing. It's our only foam. It's our only bordered foam. And so we have regular Mepilex. We have one that we have in the US called Mepilex Up, and then we have the Border Flex. And so that's all we have. So we will put cadexamer iodine underneath it. We put it over collagen dressings. It's our go-to dressings for pretty much all of our patients because that's what we have. So you can combine it with anything. What you don't ever, we got to always be careful that we're not layering too many things, because they really don't work. I've found out that people are putting a hydrogel down and then a calcium alginate and then this and this, it's counterintuitive. So, but you can use the Border Flex. It doesn't have to be used with with any kind of gelling fiber. We use a lot of it all by itself once the exudate has reduced. So you can use it over whatever you want, and then you can use it by itself for sure.
Yes, and there are many other questions, similar. What about inodine, silver, proviodine? Many similar questions.
Yeah, so inodine we don't have in the US, but I know what it is. It's an iodine. I understand it's an iodine foam. If I'm correct on that, then I don't see the point. And the only foam that we would put on a Border Flex on top of is when we may be using like the pigmented foam, like Hydrofera Blue. We will put that on and put if we're looking for a different type of a goal with our patients. We've used that under, I mean, this is our secondary dressing on pretty much everything. Unless it's a very large wound, then we have to use something else. So you can combine it with pretty much anything. But they mentioned inodine, and what was the other thing?
The other one was proviodine.
Oh, povidone iodine. Does
Yep.
that look like it could be povidone iodine?
Yes.
Okay, so povidone iodine is not something that I would suggest using on any kind of routine basis. You saw that I cleansed that peri-wound skin with it, but straight povidone iodine is toxic. And that in and of itself will slow down your wound healing. So if you feel the need to use iodine, then we use one that's in a gel or in a pad. That's a cadexamer iodine. That's a delivery system. There's another foam that has iodine. You have inodine or inodine, if that's how I'm saying it. So, but I would try to avoid using povidone iodine because it is toxic. It's meant for intact skin, not for open wounds.
Can you use a foam dressing under the Meplex border flex? Yes, you just answered that.
I mean, you can if there's a reason to do it. And the only one that we ever use is again, Hydrophera Blue. If we don't need that much absorption. And usually we use that because of what it does to the edges. It flattens out edges and some other reasons that I don't know if we have time for me to go into that. But yes, you can use a foam on a foam, but you want to have a good reason to do it. Like if you wanted to cut an inodine dressing to fit the wound bed and then cover that with Meplex Border Flex, because I think dense foams, and this is why we use the pigmented one, will help to flatten out edges sometimes. And so if you feel like peri-wound bacteria and bacteria in the wound is an issue, but you don't have a lot of exudate, for example, so you don't need a gelling fiber, then you could probably cut your iodine to fit the wound and then cover it. It's definite duplication. I'm not sure. I haven't ever, because we don't have it in the US, I don't know if it's self-adhering or not, the inodine, but I guess you could. I guess you could is my answer.
Okay, and I think I'll read the last question. So for someone that has a lower leg wound with very poor peri-wound skin, dry, woody, flaky, and fragile, will you still use a board flex that might not stick well? Or is there something else that you recommend that could be held unwrapped with cling gauze?
Yes. Okay. So since let me see. I have time. This is our last question, right?
Yes.
Okay. Yeah. So a couple things. One, my strongest recommendation is to get rid of the scales. If they have that bad of a dermatitis, you may want to get a prescription for something like triamcinolone. We use the ointment. You can't use nothing that's going to adhere to it. But we also do our best to descale. I have those fluorescent pictures of the underneath side of scales, and they hide a lot of bacteria. So, and if this person wants to reach out to me, I would be happy to share our methods for taking scales off. But you can get somebody's scales off. There's a variety of ways, and I don't have time to go through it here. But once you get them off, and then you can use good moisturizing to prevent them from coming back. But if they have really a bad dermatitis, then they probably would benefit if it's just a plain dermatitis with a steroid cream. If it's a dermatitis that also has a fungal component, you can have a mixed product. So address that because they hold a lot of bacteria. So to answer the question, what about the border? It doesn't stick well on scales. So close your ears, Maria. We have actually cut the border off and then used it under a wrap. Which is not ideal, but that was before. We have a new product in the US that I hope gets to Canada eventually, and it's a newer form of Meplex that absorbs. So we've been using that also. That doesn't help you a lot right now, but yeah, you try to get the scales off because it will not stick. You may want to then choose a different kind of super absorbent that you can keep on with a cling wrap or something in order to get it to stay in place.
Yes, for that product, just stay tuned in Canada.
Yeah.
So
we'll be
Dot,
back.
Exactly. So thank you, Dot. This was a really engaging talk, and thank you everyone for attending today's webinar. Actually, we will have needed like 1 more hour to answer all the questions. A lot of comments saying how good and helpful was this session. So thank you again.
Thank you.
And if you have any other questions or we couldn't answer your question, please contact Wounds Canada at info@woundscanada.ca. And once you leave today's webinar, you will immediately receive a survey on this presentation, and we will really appreciate it if you will complete it to provide your feedback. You will
And
also have
Alina, if you do contact WINS Canada, Alina, and then they can send questions to me. So we have that method also.
Yeah, so if your question was not addressed, please send it to WUNS Canada. And also you may be able to sign up for future updates from Mölnlycke. You will also receive a follow-up email within the next few days with a link to view the recording of today's webinar from WUNS Canada. In case you need a certificate of attendance, please email info.ca@mölnlycke.com to request it. And on behalf of Dot, Mölnlycke, and WUNS Canada, thank you for joining us today and have all a lovely evening. Thank you.
Thank you. Bye-bye.